Welcome everyone to our final developmental disability clinical and research rounds for the 2021-2022 academic year. And obviously, as always, we have saved the best for last. Again, if possible, we will, I prefer to use the raise hands function so people can have a discussion or dialogue about the case that Ashley is about to present. But I guess people can also use the Q&A if they really feel compelled to do so. But just keep in mind that we are recording this for to put on our YouTube page. So if people are asking questions verbally or out loud, just realize that will be recorded and included. And I should put in a plug. It's what is our webpage called? That unfortunately you need 100 subscribers to actually name your YouTube page what you would like to. So ours is the UWO Developmental Disability, I don't know if it's UWO Developmental Disabilities Program or Western University Developmental Disabilities Program, but all of our talks going back a number of years are online there if people would like to view them. So without further ado, so Dr. Ashley Galloway is presenting a case today, which has many facets to it, or as the dude would say, there are a lot of ins and outs. So Dr. Galloway went to complete her undergraduate degree at the University of Alberta in science, but that's rather vague, I suppose.
Yeah.
Okay.
It was biological sciences and psychology.
Okay, excellent. And then moved to Ireland and attended the medical school at the University College Cork. She then saw the light and returned to Canada and particularly London, where she had completed her psychiatry residency. And Ashley has a longstanding interest and commitment to people with developmental disabilities. And so she has spent the last year completing a clinical fellowship in developmental disabilities here at UWO. And in August, I believe, we'll be moving to British Columbia and we'll be working essentially full-time in the area of developmental disabilities, which is a rarity. I remember talking with Peter Zatmari from Toronto about probably 10 years ago about how often we saw residents who went into developmental disabilities full-time, and it is not a very common thing, but is incredibly needed. And I think that the province of British Columbia is very fortunate that Dr. Galloway will be moving there to work with them. It is our loss. So Dr. Galloway will be presenting a case today. I actually don't have the title in front of me. I apologize, but Ashley, the floor is yours.
All right, so let me just share my screen here. And okay. So the title of my presentation is Lessons Learned Over a Year, Management of Severe Behavior in a Medically Complex Patient. So we'll start by going over some of the case, and as Dr. Nicholson kind of alluded to, and that the slide or the title slide alludes to, it was indeed a very, there were a lot of ins and outs to this case. There was a lot going on. And so obviously not all of it will be touched on. I've tried to hit on the key points and kind of the major things along the way. And then we can have a bit of discussion about it, either at the end of the case or along the way if people have questions. And if Sarah or Dr. Nicholson can kind of keep an eye on that for me if people have questions along the way. And then I have just a couple of learning points that I took away from this case, some reflections, as it was probably the case that took the most of my brain power over this year and was kind of the most perplexing at times. And so we'll go over some of those as well as learning points, either for, in cases these are things that you've never thought of for yourself, or even for things to think of in terms of teaching to learners, either med students or residents, as you come along, as some of those intangible things about being a consultant and running a practice that you may not think of until you're kind of in it. And then these things come up. So to begin, I have nothing to disclose. I would like to give a thanks to Dr. Jacqueline Ogilvie, who has been co-managing this patient with me along the way, and who shared some of her slides with me about this patient from a previous presentation, as she had distilled some of the past history and things already. And so I thank her immensely for that, because it was already quite the chart review to go through. So as an introduction, so Greg is our patient. He is a 12-year-old male. He currently lives with his mother and his older brother in a townhome, and has a split custody agreement with his dad, where previously he would have spent 1 week with his mom and 1 week with dad. However, this hasn't been the case for several months. Or several months now, not several weeks, due to his significant aggression. So Greg was referred to pediatric developmental psychiatry to Dr. Nicholson by Dr. Ogilvie in probably early 2021, and was triaged to be seen by myself in early August of 2021, just as I had started my fellowship. He's one of the very first patients that I picked up in starting my own clinic. The initial referral was for aggressive behavior, with excessive appetite that was worsening on risperidone, and possible OCD type behaviors. So I did mention he was medically complex. So this is Greg's past medical history. He has at birth, he was diagnosed with a unilateral right-sided spastic cerebral palsy due to an in utero stroke, which is a grade 3. So fairly severe, but he is not restricted to a wheelchair, for people who don't know what that grading system means. He does have an intellectual disability, which was pre-existent, further to his second stroke, which we'll talk about in a second, but he likely then suffered further impairments to his memory and executive function. He recently was tested formally, and I found to have intellectual disability of a moderate severity. He did have a history of behavioral issues prior to coming into our clinic. This was, again, aggression. It was much less in intensity and was successfully treated with risperidone at that point. He had, following his history with cerebral palsy and his stroke in utero, he had then developed a drug-resistant or medication-resistant epilepsy, which was ultimately treated with a left hemispherectomy at age 9. This brought about the resolution of his seizures. However, he then suffered an acquired brain injury due to a midbrain stroke with raised intracranial pressure following this surgery, and that's the second stroke that I had mentioned. Because of this, he now has multiple pituitary hormonal deficiencies, including diabetes insipidus, hypothyroidism, or central hypothyroidism, central ACTH or cortisol deficiency, and a central growth hormone deficiency. He then, following the stroke, suffered from hypoarousal, which was resolved with bifentin. He has a left-sided cranial nerve 3 palsy with mild visual impairments that underwent surgical correction, but he remains impacted by this. He suffers with dysautonomia that had an initial resolution, and then over this last year had a reoccurrence. He's been diagnosed with Pott's disease. And he has a long history of sleep dysregulation, for which he was seen by Dr. Shapiro in Toronto just recently, and he was identified to have a central melatonin deficiency. In terms of the history of aggression, as mentioned, he did have a pre-existing issue with this in the past. It had been well controlled with risperidone and some limit setting and counseling. The current aggressive presentation that began in 2021 initially only started at his dad's house, and it was described to occur out of the blue, where, for instance, they would be sitting on the couch watching a show and Greg would lash out and start hitting at his dad. Around this time, his dad decided that because of his aggression, he could no longer support Greg in his home. And so his dad brought him back to his mother's house, and he has remained at his mother's house ever since. At the start of this and around that time, triggers were identified to be around limit setting, if triggers could be identified. As I mentioned, it was fairly out of the blue for most of the time. He was being seen through Pabacop at that time, which is the Pediatric Acquired Brain Injury Clinic, by Dr. Ogilvy. And so they did some counseling with Greg and with his family, and ultimately increased the dose of risperidone. Unfortunately, that increased dose in risperidone resulted in an increase in his appetite and a fairly dramatic weight gain. That led to some significant food-seeking behaviors, which ultimately turned into the main trigger for aggression and has remained so to this day. By the time of the initial assessment by myself, there had been several significant aggressive incidences involving Mum, including one fairly severe incident in the car, which resulted in Mum having a concussion. And this was around Greg not being able to buy a particular snack from Shoppers when they were there. As I mentioned, triggers now typically revolve around food seeking and related limit seeking or limit setting to that. So if Greg has decided that he wants a snack, he will go downstairs and start screaming at his mom. If mom says no, that typically will lead to some aggression. This has escalated significantly and dramatically. Mom started having to lock and hide away all of the food in the house. She's had to put locks on the fridge doors. Most of the food is actually kept locked in a separate fridge and in separate pantry space out in the garage, which so far Greg is not aware exists. And Mom remains very concerned as to what will happen when he does figure out that that's where the food is. In the past, when she was locking cabinets and locking the fridge door in the kitchen, Greg would slam on the doors, break the doors. He has broken cabinet doors off. He's thrown things. He will throw furniture or his walker. He will become significantly aggressive to people in the home, particularly his mother, but also his 16-year-old brother, to his grandmother who was living in the home for a time, to their family dog. He will kick holes in the walls if he can get to it. He pinches, hits, bites, throws things at people. And it tends to be fairly dramatic and escalates very quickly. It's also resulted in some fairly dramatic, unsafe behavior, in which we had a string of a few weeks where Greg was running away from the home in order to get more food, including one instance where he was missing for several hours. He'd actually run out to the street and flagged down a car. He'd gotten a ride with a stranger to a local metro. He then walked around the metro with a store clerk, picked out a fairly large amount of food, and then got that store clerk to buy it for him, saying that he wanted to buy food to help his mom. And then asked strangers in the parking lot for a ride home until somebody agreed to drive him back home, which, as I'm sure you all can appreciate, was very upsetting to hear about and very frightening to think of what could have been the outcome of that. In terms of the hyperphagia, which is related, I mean, the aggression is the main issue that I have been seeing Greg for. And Dr. Ogilvy has more been targeting the hyperphagia, although we've both been working together kind of back and forth. And as I said, it's very much related. One is very much related to the other. So post-stroke, he did have rapid weight gain due to a growth hormone deficiency. That did level out and then dramatically increased again with the risperidone. That leveled out again once we titrated off of the risperidone. He never did lose any weight. However, the binging and food seeking has been so severe in the past few months that he has again gained quite a bit of weight. As you probably heard, and when we first saw him, the binging and food seeking was associated with some perseverative behaviors that I know the Pabacop team were wondering about possible OCD, which is why they sent to us. This was around doing up his laces over and over again, hand washing, erasing work multiple times, and he would identify that this was because he needed to get it right. This didn't respond to any kind of visual stimuli or cues for him to move on, and could lead to explosive behavior when people were trying to intervene. He sometimes would respond to some limit setting around how many times he could do something over and over again. However, we had discussed it, and we'll talk about some of the medication steps that we made. We did introduce some fluoxetine about midway through this year. And the OCD behaviors no longer seem to be concerned. They haven't reappeared in some months. And in all honesty, like, I don't recall it being a major factor in the start of the fluoxetine. That was more about, he had started to identify low mood, that he was feeling sad all the time, and his mother was stating the same, that he appeared to be sad, that he was feeling badly about himself, that he was quite tearful at times. And so we had started fluoxetine. So the OCD behaviors are no longer an area of concern that we're working on. Now, with all of that medical history, the aggression history, the hyperphagia, which I should mention, I forgot to put it in there. We're not talking about just going and eating excessive snacks. It was also, if mom left apples out, at the beginning of all of this, he would eat an entire bag of apples, or fruits, vegetables, no matter what it was. It has also progressed to the point where he will eat raw ingredients. So mom has caught him eating raw flour, uncooked oatmeal, things like that, like straight out of the bag. So we feel fairly safe in that this is a very centrally driven hunger that he can't seem to control. And that we have not been thus far very successful at managing or helping him with. And so on top of all of that, there have been some significant psychosocial issues for Greg. Key among them is this constant theme of abandonment on the part of his father. So it started with not being able to visit, not being able to go over, which was something that, although I didn't have a ton of time in my clinical work, I did have Greg in for, arranged to have some sessions of actual therapy with Greg to try to get him to talk about what was going on between him and his father. And Greg was very good at vocalizing and stating to me how he felt angry and sad and didn't understand why his dad wouldn't let him come over, and what he had done wrong to make his dad be angry with him. And then right before Christmas time, we were having a group session, and his father and soon-to-be stepmother shared with myself and with Greg's mother that although it had been being planned for several years and that Greg had been very much looking forward to it for all that time, they had decided that Greg was no longer able to come to their wedding in Hawaii in the early new year of this year, which was something that Greg took very difficult. He very much struggled with it, and resultingly, there was a massive upswing in his aggressive behaviors at home over the time where he was supposed to be going for this trip and when his brother was going, and then shortly after his brother got back and was sharing stories and things of that nature. And it was very difficult for them to move through and remains something very difficult for Greg to process. Another thing that we've been working with Greg on, and that has become quite a theme, is that, although he has this intellectual disability, and if you were to meet Greg, he certainly does present as a much younger child than 12. He is also becoming aware of his own limitations, and of his own disability, which has been something that has also been a very big struggle for him. Again, there's this constant theme when we talk to him about loss and grief, not knowing why he has to be different and why he can't just be like the other kids in his class, and why we as a treatment team can't just make that happen for him and make him be like the other kids. Another stressor was that they moved house in mid-2021. And then this is also all in the background of just this ongoing theme of medical trauma for Greg, multiple hospital visits, multiple painful procedures, many physician appointments. And then as we kind of talked about, the limited inclusion in school, and the unknown factor of how much the other kids at his school are accepting of him, and possibly the amount of bullying that may be going on there. In terms of how things progressed over the years, over this year, Greg actually did have several hospitalizations. Early on in the course that I was seeing him, he had two about 5 days each admissions for dysregulation in his dysautonomia. He had been dropping his blood pressure through the day and in the night. And so he was admitted both times for that. That did resolve with adjustment of some of his medication. He then, towards the later half of the year, had several emergency room visits for his behavior and for significant aggression that resulted in 2 admissions to the Child and Adolescent Psychiatry unit. One admission was very brief, it was overnight. And then he was discharged back home. He had remained settled on the unit, and they didn't feel that it would be appropriate to keep him. The second admission, we were able to argue for a longer stay to provide some respite relief to Mum, who was also had a fairly significant concussion at that time as well, which was her second resulting from aggression with Greg in the year. And we also we asked and gave some advice about changing a few medications, perhaps a little bit more rapidly than could have been done on an outpatient basis, which we were able to arrange with the inpatient team. So Greg's current medications, in terms of his psychiatric medications, he's on haloperidol 2 milligrams twice a day. He is on bifentin 70 milligrams once a day. He's on lamotrigine 125 twice a day, topiramate 25 twice a day, although I believe that's now 50 twice a day. We're titrating it up. And we'll talk about some of the medication changes that occurred over the year in the next slide or two. He is on a significant dose of lorazepam. So he is on 1 milligram at 8 and at 2, and then he is on 2 milligrams each at 4, 6, and 8. And it is quite dramatic, but this is the dose, we slowly moved up, and this is the dose that we seem to have landed on that has been the only thing thus far to get any kind of handle on the aggression that was being seen in the house. He's also recently been started on a blind melatonin trial following the appointment with Dr. Shapiro. So he is on something at bedtime, but the way it was structured was that he would be taking a fairly large dose of pure melatonin sourced through that sleep clinic for 1 month, and then a placebo for 1 month. So we are actually unaware of what medication or which of those 2 that he is on right now. He's also on DDAVP 3 times a day, levothyroxine once a day, hydrocortisone 3 times a day, growth hormone injected 6 days a week, lansoprazole, midriadine, vitamin D, and iron. In terms of some of the changes, and this is a bit of a simplified slide, and it was interesting to go back and look at it because at the time when it was all happening, it seemed like a lot more was going on and a lot more was changing, even over and above what this slide says, which hopefully you all can appreciate is a lot of changes to occur over a period of time. So when he first started with me, we continued on titrating him off of the risperidone. Dr. Ogilvie in the Pabacop Clinic had already started him on lamotrigine for mood stabilization in hopes that that would help. So we just continued with the increase in that. Because I was newly starting and had a lot of space in my schedule, we actually rapidly increased that titration schedule, and I was seeing them about once a week. At one point, we had initiated and then discontinued trazodone to try to help with the sleep. It had no effect at all. We did introduce the fluoxetine and gradually increased him up on that. We then, in terms of looking at his appetite, had increased by Fenton. He had initially been on, I believe, 20 milligrams, and that had been introduced as part of the hypoarousal. So we increased him to about 50. Around the time of his long psychiatric admission, we had discussed and switched him to Foquest to see if that would provide better benefit for appetite stimulation or appetite suppression, through the evening. That just seemed to have no benefit, so we switched him back to bifenton at the max dose of 70, where he is now, to see if that would provide any relief. Through this time, we were slowly increasing and titrating and changing timing and dosages of the lorazepam. As mentioned, this seemed to be really the only thing that helped him in terms of his agitation. I'm now realizing I didn't put on this slide that we introduced Haldol, which is something that we did around the time after the initiation of the fluoxetine, as he had stabilized for a bit, and then we were starting to see more aggression coming back. The introduction of the Haldol seemed to help again for a little bit, and then we were seeing it come back again. Eventually, we settled on the lorazepam dosing schedule as it currently is. And it's something that in discussions with myself and Dr. Ogilvie, Dr. Nicholson, and his mother, we all agree it's high dosing, it's frequent dosing. It's not ideal and certainly not what we want to see, but the pros and cons, weighing that against the level of aggression that was being seen in the home, is kind of what we need to be going with right now, while we try to stabilize other things in the meantime to see, and then hopefully we can bring that back down. And then just recently, as I had mentioned, again, in discussion with Dr. Ogilvie, we've decided to start topiramate, hopefully to get the same mood stabilization that we had seen with the initial introduction of the lamotrigine, as well as to hopefully suppress the appetite. The goal is that we will get that up to treatment dose and then assess and discontinue the lamotrigine, which is something that will be carried on through the summer. Other services that have been involved with Greg and his care over this year. So he's had fairly steady and significant input from social work and then developmental pediatrician, that's Dr. Ogilvie at the Pabacop Clinic, which is the acquired brain injury clinic at Thames Valley Children's. He's also seen through pediatric neurology, through pediatric endocrinology, the sleep specialist in Toronto. He was seen with psychology for testing. He's had some input from occupational therapy and speech and language therapy, but that has been limited over the last little bit. He has received a fair amount of respite in the home. He was getting respite 3 times a week in the evening. It has recently been allotted for some emergency funding. And again, about partway through this year, we initiated as a group a referral to CSCN as it was becoming clear that Greg's needs and his family needs were very quickly outstripping what could be offered in the community as we were currently trying to manage. So we actually, the social worker at Pabacop, Janice Gray, was able to put that referral in and actually was able to escalate it. We had our local resolution meeting fairly quickly, and the outcome of that was further emergency funding, and a referral has already either been placed or will be placed to CPRI for hopeful inpatient admission for a full look at his medications and other things that may be able to be offered for Greg. This was something that we felt was really important because we were starting to become very aware that my time with Greg and his family was going to be coming to an end. And all along this road, with all of these changes, with all of the differences and ups and downs in his care and things that were going on, I had been in fairly constant contact with the family. I was seeing them at least weekly. I think I could probably count on one hand the amount of times when we took more than a week's break in between appointments. They were usually added on at the end of my clinic day for the next week, kind of on just an ongoing revolving basis. I was in fairly constant contact with his mom via email on the days in between, as things would be happening and evolving with Greg, and she was needing some support and advice through that. And all along it was, fairly constant emails back and forth between me and the Pabacop team, fairly constant communication between me and the pediatric neurologist, Dr. Andrade, who was involved especially when I was involved in the neurology clinic through my fellowship. We would be meeting and having discussions about how to help Greg and his family. And it was just becoming very apparent that this was not something that could continue, regardless of the fact that I was leaving, that this was over and above what we could conceivably safely offer, and that there needed to be further support for Greg. So at this time, the current issues that are ongoing are, the number one issue for Greg right now is the hyperphagia, the over and above appetite. This continues to this day. We have not really seen any good resolution with any of the appetite suppressants that we have tried. We are attempting to control this with the switch to pyramate. It didn't really seem to come about with the switch to the with the switch to the Haldol. So, in discussion, we don't really think that that's what was going on. We also didn't really see a good resolution of the appetite when we titrated him off of the risperidone. In discussion with Dr. Ogilvy, the hyperphagia is not totally uncommon for the brain injury population, but it is something that is very, very difficult to control when it does occur, especially if it's not, if it doesn't respond to your kind of standard treatments, like using the stimulants or medications like that. There is some ongoing aggression, although it is much better right now, and we're kind of in a tentative holding pattern on it for the moment. As we've talked about, it has the containment of the aggression has required those high doses of benzodiazepine in order to contain it, which has been a trade-off. And for right now, especially Marsha's mother has said, she's willing to have the trade-off of a little bit of the sedation that he continues to have with the lorazepam through the day, in order to assure that she's not living in fear of her own child in their home. It had gotten to a point where she was very concerned that he would significantly hurt her or put her in hospital, or even, more severe, dramatic than that. And then her question was always, well, what will happen to him if I wind up in hospital because of my injuries? There will be no one to take care of him. He does still struggle with ongoing sleep issues, and the melatonin trial is underway right now. He will go to sleep fairly easily around 8 o'clock once he receives his last lorazepam dose. He is sedated and tired through the day, but he's also not sleeping through the day. So we're relatively sure that that's not the case or the problem. And then he typically will wake up somewhere between 9:30 and 11:30 in the evening, and then is often up for the rest of the night, which has caused a lot of concern for mom. That's when he will do the bulk of his binge eating because she's not there to monitor all the time. It's led to significant sleep problems for her as she gets up and tries to coax him back to bed. That's where the bulk of the intense anxiety or the intense aggression would be occurring, as well as the fears of him again absconding and leaving the house. Thankfully, that hasn't been an issue since it arose kind of in the mid-ish winter, February type time. But it remains something that his mother has worried about. More recently, Mom has noted that Greg is starting to want to refuse to engage in activities that he previously would have enjoyed. Things like going to soccer, Special Olympics soccer, to Special Olympics baseball, things that were events that he very much looked forward to. She's having to coax him to get into the car, and then trying to coax him to get out of the car once they get there. Initially, Mom was saying it was like an anticipatory worry. He's saying that he's worried or afraid. We've been talking about it and we're not sure, given the amount of Ativan that he's on, how much worry he may be feeling, or if it's a true anxiety. We wonder about it continuing to be the sedation effect. Up until recently, he didn't really have much to do in the evenings or afternoons, and therefore could just be in the house watching something on the iPad, being on the couch. And so perhaps he is still more sedated. Mom was going to spend a bit more time talking with Greg about the feelings he's having in his body when he talks about being worried and afraid to go to these events. And it's something that I have planned to talk to him when I meet with them next week for our next session, to see if we can get a little bit more insight into what is going on there. Regardless, it's something that's new for Mom, but she has been successful in getting him out to these events. He's not actually missed anything yet, which we've encouraged her to keep ensuring happens as much as she can. And then finally, the next issue that we are upcoming and anticipating is the quote unquote abandonment by the treatment team, meaning me, and the fact that they have, for better or worse, gotten quite used to having weekly support over this last year. And in the next 2 weeks, once I leave, that will be ending. They will still be followed by Dr. Nicholson. They will, of course, still have the Pabacop team and the rest of their physicians. But they'll be kind of going back to the schedule that they had previously, where, they see Dr. Ogilvie every couple of months and they'll see Dr. Nicholson every couple of months. But that level of support is going to dramatically decrease. It's obviously something that we've well prepared the family for. The mother very much knows that this is coming, and she's been very, open and accepting of it. She's not been upset. She, knew that at some point I would be leaving because I was a fellow, and has been very grateful for the support that we were able to give for this year. But we do anticipate that will be another stressor that will be coming up very quickly for this family. So I realized that was a bit helter-skelter and kind of ran through things kind of all over the place. I did try to clean it up as best as I could, but part of me also left it a little bit helter-skelter, because it was, as we were going through all the ups and downs and everything this year, it did feel very all over the place, and it felt like every week was something new, and something had changed, and something was maybe a little bit better, and now we have this new thing that's worse and causing problems. And what do we do? What do we do? What do we do? That was always, kind of the pressing, urgent issue. And so, like I said, I had some takeaways from the case, less medical knowledge wise and more just kind of case management, clinic management wise, that I had been thinking on over the last little bit. But I was just wondering at this point if people had any questions about Greg's case, or honestly, and Jackie and I would be the first to say, if anyone had any suggestions to, we would be very open to it. I'm just going to exit out because I can't actually see what's going on if I'm sharing.
Unfortunately, actually, I can't see Jackie.
So Jackie wanted to be here, but unfortunately wasn't able to. There was I've lost the word. She had something else going on at this time that she couldn't miss.
A prior commitment.
Yes, that's what I was looking for.
So I think in psychiatry, and I think you know my opinion about this, but I think we have a real aversion to using benzodiazepines, and we're taught often, we shouldn't use benzodiazepines and we should only use them for short periods of time. I mean, what do you see as the time frame for him to be taking lorazepam?
I mean, my best case scenario, what I wish would happen answer is as short as possible, that hopefully, that this topiramate will help suppress his appetite. That is what has been driving much of the aggression, at least for the last 6 months. And so that will make that less of an issue. And then we can start to taper it off. And so, by end of summer, we're looking at starting to taper off his lorazepam and see where we're at. The realistic answer is, I don't know. This may be something he's on long-term, just by virtue of the fact that we have to keep in mind the safety of both Greg and his family. It's been, very dramatic, and his mother's physicians were very concerned about what her outcomes would be, especially if she suffered another concussion. She's had at least 2 fairly severe ones, fairly back-to-back within this year.
So when you said you would like to get reduced to lorazepam fairly quickly,
not fairly quickly, but like to start to taper that off within the next couple of months. If the topiramate went well, if everything went well, if things are, best case scenario. And that's more of a personal, I don't like benzodiazepines as a drug because I have a bias against it. I don't like using it unless I have to. Like, this was a case where I had to use it.
Fair enough, but I think in this case, if it actually makes a difference, and so if you tried to start reducing it and things went south, would you push it back up?
Yep.
Yeah, and I think we have to do case by case kind of thing in a way. So before we get to Claire, so Joanne Morrison had a question about, has he ever had genetic testing or been tested for Prader-Willi syndrome?
I don't know that he's been tested for Prader-Willi in particular. I don't have the results offhand. I do know, especially when he was being seen more through the neurology clinic, they did do genetic testing and nothing came back of note, of significance. But in terms of the Prader-Willi right now, or if that was specifically looked for, I couldn't tell you. I don't think so.
I know that the lab, the genetics lab, will, if you indicate that you wonder about Prader-Willi, they will often look for a mutation in the gene or something like that without needing a separate requisition.
Yeah.
And I don't think he had it's so hard to know with his early history, but I don't think he had this sort of failure to thrive early on, did he?
No. So early on when he was tested, it was more, he had the in utero cerebral insult, which resulted in his CP. And then it was the epilepsy. And I believe it was more related to that and the intellectual disability that they had looked. But he did not, it wasn't until the second stroke that he had the increased appetite, which now is, 3 years ago. And it has only dramatically increased now. I think it is certainly something that, again, has been on the back of our minds, but maybe it seems more that it would be related to the acquired brain injury, knowing that it's it happened so closely in time and wasn't an issue prior to that.
But if that's the case, then what part of the brain do you think would be involved?
With the stroke?
Well, that would result in the hyperphagia and stuff.
I don't know. It was a midbrain stroke that resulted. That was with the raised ICP. So he's had fairly diffuse injury in talking to Dr. Ogilvy. And that was where we see a lot of the endocrine abnormalities that have come from that as well. And the dysautonomia.
So while you're talking, I will look up in the LHSC system, but Dr. Mitchell has a statement or a comment or a question. So Claire, go ahead. Hello. Claire, are you there?
It doesn't look like she's muted, so I wonder.
No, not right now. And she did have her hand up, I believe. Yeah. I don't think I'm hallucinating. I mean, are there any other thoughts or comments about this case before Ashley talks about sort of her own experiences with it and what it means to her personally? Because I think there's a lot of issues here, right? I mean, I think there's the ethical issues around the medications. There is the fact that he's had 2 strokes. There's the seizure control. There's the head injury part. And then ultimately his behavior. And what do we do in somebody with sort of this kind of level of aggressive behavior? Is there aggression at school also?
There's never been significant aggression at school, which was also one of the interesting things about this case. It was really limited only to at home. And over time has been really limited specifically to mom as things have kind of evolved. At school recently, he's been having there's been some refusal at school where he won't or doesn't want to do things that he wouldn't have had a problem with before, but that's very recent. And up until then, his behavior at school was unaffected. He was doing well. School had no problems with him.
And is that why he remains in a regular classroom?
Yeah.
I mean, I don't know if a developmental class would be appropriate or if he's ever been considered for it, but I guess that if he is not disrupting the class really, then that's not necessarily a concern, I suppose.
Yeah.
So Claire had just sent me said something in the Q&A that she is there, which is good to know, but that she was speaking, but for some reason we can't hear her. So I asked Claire if she wants to ask it through the Q&A. And while we're doing that, Dr. Goldberg has a question, or has raised his hand. Dr. Goldberg, if you just want to unmute yourself.
Can you hear me okay?
Perfectly well.
First, I want to congratulate Dr. Galloway. I think the challenge of the multiple problems that this young man had, I think is a stimulus for why people go into developmental neuropsychiatry, because of the complexity of it. And the fact that you've been hanging in there through all of this to take a look at the neurological, the behavioral, the types of things, and then to manipulate the medications is very important. And I think while we're doing this, we also need support for someone as complicated and complex as this. And I gather you've received support through all of this, be able to bounce your ideas off of someone. Now, it looks as if you also are having a sense of abandonment and you want to be reassured that this young man is going to be looked after, and you're tossing the torch to Dr. Nicholson. But the two other things that seem to be missing from the people that are involved, and that is a behavioral psychologist, behavior therapist, and the other is a social worker to take a look at the family situation. So it seems to me that that's where the social worker comes in terms of looking at the abandonment type of thing, the relationships, the feedback between the young man and his family, and then the behavior therapist to augment the medications. And I haven't heard if there have been a family therapist or a behavior therapist involved. Seems to me one needs to add that to the ongoing thing. And it's a frustrating kind of situation, but that's where Rob and developmental neuropsychiatry comes in.
Yeah, no. So they do have the social worker with Pabacop, but their role is largely more in like connecting to resources and less that kind of family therapy role, or looking at those family connections. Although she does do some of that as well. And she has been, a bit of a godsend through all of this in terms of navigating all of the, just trying to get resources where we can. I totally agree with you that having a behavioral therapist or a family therapist or something to that degree has been something that has been sorely missed, but access is difficult. As I know everyone here can definitely agree with and understand. Unfortunately, the way that the clinic is set up that I was in at LHSC, we don't really have access to that. And I know that that's, the number one thing a lot of families ask me for. That's a bit of what we were hoping, like once we get to CPRI, well, I know, of course, it's not a perfect world there either. There's a little bit more in terms of other supports for this family. And look, while we're waiting and in the outpatient setting, like looking externally or looking privately, there's just not a ton of funds available to this family. Mom is supported on ODSP, and although has been full-time supporting this young boy through all of this, has no kind of funding arrangement with the father because their original arrangement was for 50-50 time. And so the funding was set up according to that, where neither would contribute to the other because they were spending equal amounts of time with the children. So that has been unfortunate. And then, just another one of the social aspects and social pieces that we've been navigating with the family. I would say thank you for your kind words. It was a very interesting case to have as a new, a fellow, a pseudo consultant kind of managing a case on my own with a lot going on. And I think initially when I first took it on, and as you might see in some of the takeaway points that we'll talk about in a little bit, it was definitely a lot. It felt like a lot, and I'm glad I had that experience though. While I did have the support, I was able, we were doing weekly supervision sessions with Dr. Nicholson where we would talk about the case and kind of bounce ideas back and forth. And I also had the team with Pabacop as well to kind of work together. And absolutely, you're right. There is this element of I am concerned and have some abandonment issues of what is going to happen to this family when I go. Because I have been so involved and just trying to get them week by week and what's going to happen. And that is also another one of the takeaways. So I know there's other questions, but just looking at the time, I'm wondering if it might be worthwhile if I just pop those screens up and we can.
So actually, if I could just say a couple of things. So I think one other thing too, is that what's I think really nice about working in the developmental population is that there are often many people, but I think we all tend to know each other. And so the fact that you could just call Jackie up or whatever and ask a question, I think is often really, and the same with, if the neurologist was seeing, he also sees an endocrinologist. And I think all of those things, if I could just ask those other two quick questions by Ashley or comments. So one again was from Joanne Morrison. And interestingly, just to go back to your question earlier, Joanne, I cannot find in his LHSC record any report of genetic testing. So, I mean, I would assume that it's been done, but there's one other place I will look in a second. But Joanne asked, so when this boy has respite, is that somebody comes to his home or does he go for out of home respite?
So that is a respite worker that comes to the home with mom still there, although she's not an active participant, but she has remained in the home. And Greg and the respite worker remain in the home right now.
Because I think Joanne's question was if he went out somewhere, so if he went for overnight respite somewhere, I guess the question would be, what is his behavior like in a setting that might be more structured and things like that? But I guess we can't answer that.
We can't answer it. And I know early on, there had been talks of, approaching different places for out-of-home respite or for different services. And the continuing theme that always bounced back for this kiddo is he was either too behaviorally complex for the more medically focused sources or resources, and he was too medically complex for the more behaviorally focused resources. And so he was kind of excluded from all areas because of his complexity.
And I think the other issue that this really highlights is, and I don't want to use the word inequity, but I can't think of a better one, that we know if Graham had a diagnosis of autism spectrum disorder, he would get access potentially to many more funds. Whether he'd be able to use them or not is a different question altogether. But because he doesn't have autism, he doesn't have that access. And so it just creates a sort of situation where his needs are as great or greater than the vast majority of people with autism, and yet doesn't get the same access to services. So Claire's statement was, so she attended a conference in Naples, Florida on essential psychopharmacology just before the start of the pandemic. And it was led by Carl Saltzman, who is from Harvard. And Claire reported here, he made a distinct effort to suggest we use benzos in some cases. And the session itself was called Benzodiazepines in Today's World, a Blessing or a Curse. And what apparently he concluded was that they are a useful group of drugs for some patients if they're used carefully and appropriately and monitored. And I think in someone like Graham, this is what I've said to parents sometimes, is that realistically, I don't think we really would have to worry too much about Graham abusing them at this point, because he's not going to be hanging out at Richmond and Dundas or whatever trying to score lorazepam. If anybody was going to be abusing it, it would probably be his mom. And not that we're concerned about that, but it'd be more likely her than anybody else. And so if anybody's interested, I don't know if everybody else is able to see the Q&A, but I will copy what Claire had put here and put it in the chat. There's a reference in the American, so you can see it?
No, I'd like to
see it. I think you can see it.
I will also copy it though and put it in the chat.
Perfect.
And that way we can, I'll just put it there for, let's see, everyone. And I assume, Claire, is this from the, from the American Journal of Psychiatry in 2014. Okay, so actually, why don't we turn it back to you then?
All right, so I'll breeze through these a little bit quickly. Like I said, these are more just kind of considerations that I will take with me into my future life, future consultancy, all of that. So lesson number one, even though you think it is helpful to see people really fast because the schedule allows for it, ultimately it may not be helpful for you or the family to set that kind of precedent. It was set up when I started seeing them in August as, oh yeah, I can see you weekly to kind of get a handle on this, because I didn't have a lot of patients and I had a lot of space in my schedule. But as that became less and less the case, it was harder and harder to schedule them in and make sure that I had time to spend with them. But it had also been an unspoken expectation on the part of the family that I would be there to handle these kind of things that came up. And I want to impress, like, I don't want it to seem as though they were insisting that I see weekly. The mother was very lovely to deal with, and I think certainly would have been understanding had I said, oh no, I can't see you till next month. But it was just something that it was, oh, well, we'll talk about that next week kind of thing. And not just that it sets that kind of an unreasonable precedent, but it also, I think, and this is something that Dr. Nicholson and I had talked about, was, longer times in between appointments allow more time for medication changes to occur and take effect. I will talk a bit more about my reflections on the medication changes that were made in this case, I think in a slide or two. But I'm not ultimately convinced that the amount of rapid changes that we made in Greg's case was really that much helpful, or more helpful than maybe a slower schedule. The longer times between appointments also allow time for the family or for the patient, if that's who you're dealing with, to see more behavioral change, or for mood changes or whatever it is, evolve over time. It's very difficult to say that something is working or is helpful in a week. But if you come back to them in a month or 2 months, they have more time to reflect on that, which is also helpful. Of course, now this needs to be balanced with allowing for a means of emergency contact and management when needed. So that's not to say that there weren't times when things were very dramatic going on with this family that of course needed to be responded to very quickly. But there were also a lot of times when things were just kind of slowly trudging along, but because that pattern had been set, it was, well, okay, well, we'll just keep seeing every week. It also brought to mind the pros and cons of a patient or patient's family having a physician's work email. This kind of came about a little bit by necessity because of the way the fellowship is structured. I was able to utilize Judy, Dr. Nicholson's admin for scheduling of initial consults and for some things, but obviously she's very busy and couldn't fully support me in terms of all the other needs like follow-up, her being able to field emails, getting documents from families. So it was set up as something that made sense for them to just have my work email. Now, I would say 98% of my patients and patient families utilize this very appropriately. It was to send me documents that I had requested. It was to inquire about when our next appointment was if they'd forgotten to write it down, or to let me know about major events. And that was primarily how Greg's mother utilized this function. She would let me know when Greg would have a major aggressive incident. She was very appropriate with it. Often I wouldn't even respond to that email because I'd be seeing her in a few days because of an appointment that had already set up. That had been discussed with her, and she understood that it wasn't something that she needed a response to. It was more just a way for her to ensure I knew all the details. And then we could kind of hit the ground running at the appointment. That is to say, however, there were others who were not very appropriate with having that resource. And it did create some issues that Dr. Nicholson and I had to navigate. Regardless, however, of Graham's mother's intentions and the appropriateness or not, it did add to that personal feeling of needing to do something very quickly for this family and perhaps needing to rescue them out of this space that they were in, this very unfortunate situation that they were in. Also reinforced the need to be very systematic with medication changes. The idea of doing one thing at a time, focusing on one medication at a time, and leaving other things alone so that we can be sure what is, cause and effect. We did mostly manage to avoid changing too many things at once with Greg. That is something that we did very quickly change a lot of medications, but we were fairly successful at making sure we focused on one thing at a time. There were some changes that were made simultaneously, and that was largely due out of necessity, especially when things were dramatically bad. For instance, we added Haldol at the same time that we were increasing bifentin, just because we needed to make some dramatic changes at that time. It also brought up some pros and cons of the med changes being made very quickly, and that's something that I alluded to before. On the one hand, we were able to trial a lot of things very quickly and assess whether or not it was going to work very quickly. On the other hand, I think it also set up a bit of an expectation for everyone that things are just going to happen very quickly, that a med change is going to bring about resolution very quickly or make a dramatic difference very quickly. And as we all know in this population and with the medications that we use, that is often not the case. And then finally, I think one of the biggest things that came out of this case for me was learning how to manage my own and my patients' expectations of what can reasonably be achieved and working with me and through a clinic like this. And it was a bit of a hard lesson to learn, this idea that I cannot and will not be able to fix everyone or fix everyone's problems that they bring to me. I think we all come into medicine with an idea that we want to save people and make life better. And that's part of, you know, being very altruistic and wanting to do good. But that's not realistic, and especially not realistic in this population. And it's something that prior residency rotations, I think, didn't really allow for that learning to sink in or that learning to occur. And that's not, I think, a fault of theirs. I think that's just the way it's set up. You know, residency rotations happen fairly quickly. You know, you're typically on a rotation for 3 months. And that's often just enough time to start to change something or start a medication or increase a medication or do something, maybe see some initial results, and then you leave and move on to something else, and you just assume it continued to go very well and that it continued to provide benefit. But you don't really see that follow-up where sometimes things go well for a while and then they just get worse again, or they plateau off, and then you're left wondering what to do at that stage. And it also reinforced the idea of just listening to a patient or to the family is sometimes helpful enough. I know at several points, Greg's mother saying to me that, you know, what I would explain to her again, you know, we're not really sure where to go from here. We're going to try something else, but we need to wait, or I don't really have much else to offer. And her saying, you know, being very understanding and saying thank you, and like, and that it was just good to have someone to talk to about what it was they were going through, and to have that space to be able to kind of process the difficulties that they're experiencing as a family. So those were the kind of the higher level takeaways that I had from Greg's case, and working through it. As I said, I'm ultimately very grateful that I got a chance to work with them, although it was a case that, you know, took up 90% of my brain power at most times, and I'm sure gave me more than a few extra gray hairs that I didn't have prior to starting to work with him. And, you know, I do hope that things go well for him and his family in the future, and that they're able to get a handle on what's going on and things stabilize for them.
So I guess actually just to think about the last comment, do you think that, and do not take this the wrong way anyway, but I think that in residency, we tend to learn that we can know anything. Do you think that working with Graham over a period of time helped with humility, I suppose?
Yes.
Which is not to say that you were somebody with a lot of hubris or anything like that before, but I think it's just that recognition that, and I don't know if it's always apparent in residency when we see people.
Yes. And I mean, you were being very kind. I do think I came into this fellowship, though, with a fairly large amount of hubris. I think most people do. I think there is an idea of, like, you come out of residency, I think, aware that you're new and maybe are a bit shaky, but are, you know, I think most, or at least feel like, oh, I got the medicine side of thing. Like, I've done that for 5 years. Maybe it's the other stuff I don't really know much about. And like I said, I think that was the biggest takeaway for me from this case, was that despite best intentions, despite banging my head against the wall and looking things up and trying to figure stuff out, sometimes there isn't a nice, neat answer, and we just won't be able to do much other than just listen.
Do you think then, it seems to me that residency in psychiatry in particular has moved more and more biologically over the number of years, certainly since I was a resident, without sort of focusing on the fact that sometimes just being there and listening can be beneficial to some people. And not to minimize, obviously, the use of medication and stuff, but do you think there's enough emphasis on what medicines can't do?
I think they try. We do still have at least the requirement of being supposed to do, a couple long-term psychotherapy cases in different realms. And again, that's why at the time I was and I can still consider myself very lucky. I had the same patient for CBT that rolled into psychotherapy or psychodynamic psychotherapy. And she was what you would consider probably the most ideal patient. She was always on time. She always showed up. She was very keen. She was very eager. She always did her homework. She was very open to it. And by the time we finished there, the therapy came to a very natural end of where, a lot of the issues she had come to me with had resolved, and she was in a much better space. So it was almost this like fake reality of what to expect from that kind of outcome as well. Whereas perhaps some of my colleagues who did more of the long-term cases that didn't go well or that didn't have response, maybe had that learning a lot earlier than I did, where you sometimes can't do much to help and change, and you just have to listen. And that's all you can do.
And I think learning how to cope with difficult families also, so that one person who had threatened to call the college about something that was not college calling worthy, and it never happened. But I think sort of learning how do we handle those kinds of situations. Are there other, or let me rather, what other comments or would people like to offer sort of about the case that I think is pretty rich in a number of areas, but also in sort of what Ashley's written about her experiences over the past year? Actually, by any chance, are you living in a wind tunnel?
No, but it does get pretty windy up here.
Oh, there's like a wind kind of noise in the background. Maybe it's just me, but
it might be. I'm almost directly underneath one of the air conditioning vents. The only spot where my desk could be.
So how will what you've learned in the past year and working with this young man and his family help you when you move on to your own practice starting in August?
I mean, like I said, that kind of main key takeaway of just not having that expectation going into every patient that I'm going to be able to do something to fix them. And also, and this was something that I learned working with Dr. Rao on the adult side, and something that he does quite often, where if there's an issue going on or something that's happening, he will often not do anything right away. And he'll say, let me go away and think about this, and I will get back to you with an idea of what we're going to do. And I don't know I think that that's also something that is very appropriate as well, to say, I don't want to make a quick call in this moment. If it's something that's a bit more complex, let me go away and think about this, think about what is best to do here. And, we'll meet again and discuss that. I think in a fairly short amount of time, that's reasonable. I do have to say, I am looking forward to a time when I will have a full-time administrative assistant, or at least somebody who is dedicated to help me on a bit more, with a bit more time than what Judy graciously gave me, out of the kindness of her heart, so that I don't have to be the one fielding all of the emails and phone calls and doing all of that arranging, because I think it adds an extra layer of complexity that didn't need to be there. Because it also provides, I think, a bit of distance at times when if somebody is directly appealing to you to say, like, please see me, and it's directly to your email, it's a very hard thing to say no to that. Even if it's in the best interests, perhaps.
So it's better to foist that off on somebody else?
Well, if somebody else is able to say, here's when her next available session is, rather than, sure, let me squeeze you in when technically my clinic day is over, or let me squeeze you in over lunch. Both for the person who's responding to that plea, it's not their issue. So, it doesn't bother them any. And I don't have to do it. So I don't have to do the, oh gosh, I guess I cannot eat lunch that day. That's fine.
Yeah, so it does make it sort of less emotional involvement, I suppose.
Yeah. And that's not to say it won't ever happen. Of course it will. I'm sure there'll be times when I get notified that so-and-so needs to see you right away, and the only time you can see is either after hours or at lunch. I just think, and granted, it was only one day a week that I was running this clinic, so it was, in the grand scheme of my week setup, still fine. But it was also every clinic day almost, where I was either working after hours or squeezing someone in over lunch, and that when I'm having a 4 or 5 day work week could very quickly become problematic.
Yep, I think that's sort of setting up, well, I don't think I'm a very good role model for that, but yeah, I think setting up pretty clear boundaries in terms of time that you spend in the clinic and stuff like that. So if I can, so just with regard to Joanne Morrison's question earlier about Prader-Willi syndrome, I cannot find any evidence, at least just skimming the people that have seen Graham in the past, well, 10 years or whatever, that he's seen a geneticist at all. It doesn't mean he hasn't seen somebody at LHS in Toronto, perhaps. I should also say that just to emphasize the medical problems that this person has, in 2022 alone, he's already had, it would appear, 30 medical appointments, including an admission to hospital and things like that. But that's this year alone. And last year was significantly more, just it's obviously a full year. So a huge number of problems. But, you know, so I think it also highlights that in situations like this, you really need an excellent primary care physician just to sort of be on the ball, to collate all the information, to bring it together, but also make sure stuff has been done.
Mm-hmm.
So can you do here, will you talk to Jackie at some point and just double check that with her and see if she knows about that?
The family doctor?
About genetic testing in Prader-Willi.
I will ask her. I'm almost certain it has been done, but
there's not. So in the LHSC chart, there's no notes, but again, I don't know if you can upload things to Cerner from other places. And so I think that makes it tricky also.
Mm-hmm.
So thank you again, Ashley. This was fantastic. And just if I can, you know, it's been wonderful having you over the past year and for you to be acting as a guinea pig. And I think it's certainly helped us a lot. So in terms of figuring out what works, what doesn't, and how we're going to work things in the future with fellows. But, you know, I've certainly appreciated having you around a great deal, and it's been fantastic. And I think this presentation really highlights a lot of that work that you've had to do. So thank you again for that. And well, I don't want to say we wish you all the best in British Columbia because for you weren't going, but I guess there's not much we can say about that. So if you ever decide you can't stand the West Coast, you're always going to be welcome here. So, and as I said earlier, this is our last developmental disability rounds for the year. We will start in October. And we have our annual CPD day in September with the topic to be announced. So have a wonderful summer, everybody. Hopefully it's a bit nicer than it is outside today. So Claire said, just to summarize, that this case was discussed at complex case rounds and that it seems that genetics has been done. But I just think, you know, I think the difficulty, Claire, that I see is that it's not, I didn't read through all the notes from different physicians, so maybe documented in somebody's report, but there's no separate genetics report anywhere. And there's no notes from Vicky or Maha or Tuche or Jack Young, perhaps when he was still there. But anyway, thank you everybody for attending, and thank you all for joining us, and we will see everybody in the fall, hopefully including Dr. Galloway. So, all right,
absolutely.
take care, everyone.
Thank you very much.
Bye-bye.
Bye.